Lumicite, pegulakianine, may cause serious hypersensitivity reactions, including anaphylaxis. Anaphylaxis has occurred in 4 out of 726 patients, or 0.6%, in clinical studies. Tell your doctor if you have any history of hypersensitivity reactions to pegulakianine or to contrast media or products containing polyethylene glycol. Your healthcare provider should have emergency resuscitation drugs, equipment, and trained personnel available during the use of Lumicite. Healthcare providers should monitor all patients for hypersensitivity reactions, and if one is suspected, immediately discontinue the injection and initiate appropriate therapy. The most common side effects include hypersensitivity and an abnormal color in urine.
I am so grateful to be interviewing my senior medical advisor, Dr. Barry Rosen. He's a breast surgical oncologist in Chicago. And today we're going to be talking about getting all the cancer, and specifically a lumpectomy, what it is, what the breast surgeons do to make sure that they do get all the cancer. And as always, Dr. Rosen is teaching me how to get this information out in a patient-friendly way. And so we're going to break down one of the latest advances in breast cancer surgery as far as finding that tumor, and it is fluorescence, I guess I'm saying it right, guided imaging called Lumicell by the company Lumicell. So before we dive into this, I want to talk to Dr. Rosen a little bit about lumpectomy. The choice between a lumpectomy and a mastectomy is extremely personal and emotional for many of us. I myself was supposed to get a lumpectomy, but I chose a mastectomy. When facing a lumpectomy, Dr. Rosen, how do we ensure that the surgeon is going to get clear margins? And can you take us through the journey of when you're diagnosed on what the team of clinicians do to get clear margins, which is what we all want?
Thank you, Cynthia. If you don't mind, I'm going to go back a step. I mean, no patient ever comes to my office and sits down and says, "So how are you going to get clear margins?"
They don't know. They don't understand it, right?
I think, Cynthia, you're now on the other side. You see, you're not thinking like a patient anymore.
No, I know too much. I know too much.
Yes. So let's take it back a step. How's that?
Okay.
Let's talk
That sounds
about
good.
surgical planning. Let's talk about when a woman is diagnosed with breast cancer and they're faced with trying to make this decision. What's better for them? Is it better to do a lumpectomy? Is it better to do a mastectomy? And I said this to you very often about one size fits one. You really have to personalize it for patients, looking at the biology of their cancer, looking at the anatomy of their cancer, and understanding their preferences. And then you'll come up with that perfect plan unique to that person.
Right.
And as we've talked about, cancers don't always grow round. They don't look like marbles. They sometimes do, but what's the zodiac sign for cancer? A crab. And why is that? Because cancers often grow with tentacles. That's what we mean when we say that there's a spiculated tumor. And we can't always see the tentacles. Cancers sometimes grow in a branching fashion, like grapes on a vine. And sometimes cancers grow like the solar system, where there's a larger tumor and then there's smaller tumors that around it that we may not see. And so sometimes we think in a very simplistic manner based upon what we see or don't see. So when the only imaging was mammograms, we saw a black and white image of the tumor. Now that we have MRIs, it opens our eyes sometimes to these different shapes and sizes of the tumor that takes a little bit more skill to try to plan out what we're trying to remove. So it's a complicated process trying to plan surgery. And one of the most difficult things sometimes to differentiate is whether a lumpectomy or a mastectomy is better. But let's take the simple cancers. Let's take the small cancers that are detected by screening, which is really, well over half of breast cancers, and say, if we have an option between a lumpectomy and a mastectomy, I do have a bias. If I can provide the same survival rate for a much smaller operation and with a significant amount of data that shows patient satisfaction is greater with a smaller operation, my bias is to do a lumpectomy rather than a mastectomy if we can. Okay.
Mm-hmm.
Well, let's assume that we can. Let's assume that the person that I'm seeing has the option of lumpectomy and mastectomy and is choosing lumpectomy. So then what it comes down to is how do I translate what I see on imaging with what I see when I'm in the operating room? Okay. And the
Mm.
reality is that I'm operating blind most of the time. I can't see through the tissue where the tumor is. I don't want to cut into the tumor. I want to cut around the tumor. So a lot of what I do and what my colleagues do when they're doing lumpectomies is you're operating with your mind's eye. So whether
Wow.
mammogram or other imaging, you have a picture in your mind of what that cancer looks like. All right. So it
Mm-hmm.
starts with really good imaging and with the surgeon really understanding that imaging.
Mm-hmm.
Okay. The next step is, again, translating that knowledge when operating. Historically, what we did was we put wires in women's breasts that went right through the tumor that was placed by the radiologists who could see the image. They could see the cancer when doing mammogram or ultrasound. Now we have a much more precise technology, as you know, wire-free technology. We put a GPS clip into the tumor, and it allows me to use a wand the size of a pen, and I can use that to direct myself to know exactly where the tumor is, right? The more
Mm-hmm.
precise, the higher the chance that I'm going to remove that tumor completely.
Mm-hmm.
What about if the tumor is in a stranger shape? What if it's in a branching fashion? Well,
Mm-hmm.
that's where we sometimes put two GPS clips in. We
Mm.
bracket the tumor so that
Mm-hmm.
it helps us operate with our mind's eye so we can
Mm-hmm.
excise the tumor. Now, here's the challenge. We want everyone asks us after an operation, did you get it all? Right?
I did. I asked
Yes.
that. Sure.
The reality is we don't know that at the time of surgery. We really
Okay.
don't have that information. Who can tell us that? The pathologists, the doctors who look at the lumpectomy specimens under the microscope, and they can give us the best chance of telling us, was the tumor excised completely? All right.
Mm-hmm.
When will we know that? We won't know that for days after
Torture for
surgery.
us. Torture.
Right. So when we're operating, we need certain cues to help us know if we got it all, if you will.
Mm-hmm.
It starts with imaging, it continues with localization. Well, what else can we do? Well, how about if the imaging shows a picture of the tumor? What if we take a picture of the lumpectomy in the operating room and we can look at that image to give us a better idea if I excise the tumor in its entirety? That's called specimen imaging. That has come a long way over the past few decades. We used to have to send the specimens to the breast center, and the radiologist would have to look at it for us and translate it to us. Now we have these imaging machines in the operating room with us. That's a very important question for your patients to ask their surgeon. Are they doing real-time specimen imaging? I'm really lucky. Not only do I have specimen imaging, but I have a 3D specimen imaging. So I can really understand, did I remove that tumor in its entirety? Or at least can I correlate what I've removed with what I saw on the preoperative imaging? So you see how we have all these complementary technologies
All
that
works
can
together.
tip the scale. Exactly.
Yeah.
What we've been missing, which we now have with the Lumicell, with the Luma system, is that we can inject a drug into a patient and that can make their cancers fluoresce. So when we do a lumpectomy, now I can interrogate the lumpectomy cavity after I've done the lumpectomy and look at what I'm leaving behind and seeing if there's any residual cancer left behind.
Wow.
See
Wow.
how all these pieces work together. So this
Okay.
is something, it's just the evolution of complementary technologies to ultimately help us answer that question, are we removing the tumor in its entirety? Why does this matter so much? Well, what we know is that if we do leave cancer behind, there is a high likelihood of what we call a local recurrence,
Mhm.
of tumor growing back in that space. And that would necessitate, at the very least, another lumpectomy. Usually that necessitates a mastectomy. And now, this is truly an imperfect science because when a woman in the United States goes for a lumpectomy, the chance of that surgeon having to take them back to the operating room a week or two later because they had a positive margin that they were unaware of at the time of
Mm.
surgery is as high as 20%.
Wow.
I mean, think about that. How many operations do we do in the United States where there could be a 1 in 5 chance that we're going to have to operate again? It's it's a terrible feeling. It's
Yeah,
obviously terrible for the patient, but
sure.
it's terrible for the doctor,
Yeah.
and it's also terrible for the payers. No
Yeah.
one
Yeah.
likes this. This
Yes.
is this is bad. Re-excision lumpectomies are bad for patient, provider, and payer.
Yes.
And it's these complementary technologies that I use that allow me to do lumpectomies with clear margins. My healthcare system has been following surgeons and their re-excision rates. So
Wow.
it
That's amazing.
it's a real challenge, and
Yes.
it's something that really keeps all of us up at night
Yeah.
because no one wants to go back to the operating.
Sure. So
Make
by having
sense?
these, yeah,
Yeah.
sure. So it sounds like, it's a tapestry of different innovations that, are pushing breast cancer surgery and care forward to help surgeons get as much of the cancer out as possible. So with the Luma system, this is really a chance to be inside the cavity and light it up. Can you explain a little bit? Is it literally lighting it up? And let's just say there is cancer behind after you've taken out the tumor. What happens?
Well, they have the Lumicite, which is injected into the patient earlier that morning, and then they have a direct visualization system. And so you're using a probe. The probe can see the fluorescence, and it can
Interesting.
tell us if we're leaving cancer behind in that cavity. And if it does fluoresce, then we can excise that tissue and let the pathologists have additional tissue that will hopefully significantly lower re-excision rates in the world.
So this is an FDA approved system. I am a 6-year survivor. And if I was going through this for newly diagnosed patients that are facing a lumpectomy, wow, this is extremely exciting that these advances are happening. And how do they access that is my first question. But also, is this something that breast surgeons need to be trained on? And how do we empower patients to be aware of this incredible technology?
Any new technology requires a certain level of training for surgeons. The workflow is a little bit different because we have to inject the patients with the drug that will cause the tumors to fluoresce, but that's just part of the normal workflow. But I started doing breast surgery, we weren't doing sentinel node biopsies. We were just randomly going into the armpit and removing as many lymph nodes as we could. Now,
Mm.
thankfully, we have a much more precise system, sentinel node biopsy, really being for the past 20 plus years, almost 30
Mhm.
years. But what we do is we inject a drug which causes the lymph nodes to light up, if you will.
Yeah,
So we're used to using technology like this
I
that
had that.
requires an extra
Yes.
step. It's not insurmountable, but it is another step.
Yes. And so what about when the whole cavity is lit up? Can you tell us so if a certain area is lit up, so you're going to take out that section and you'll see that after you do the specimen imaging. Is that correct? Just step by step trying to understand.
Yeah, think of the surgery, a lumpectomy, like removing an orange. If the lumpectomy is the inner part of the orange, the margins, the new margins, would be like removing some of the rind of the orange,
Oh,
if
I
you will.
understand. That helps.
So if I've done a lumpectomy, and for all I know, I've removed the tumor in its entirety because that's my goal, of course.
Yes.
And then I look at the cavity, and if I find that there is an area that's fluorescing, well, that's telling me I probably left cancer behind. Now, I don't want to remove a large section of breast tissue. I just want to shave the margin. So think of, again, removing the rind in that
Okay.
area.
Okay.
Now, if there's multiple areas that are fluorescing, then yes, I might have to remove more of the rind.
Yes. Yes.
But that's, you basically have an instrument that gives the surgeon real-time feedback
In the
of
cavity.
whether cancer
Yes.
may have been left behind. And as the studies have proven, the studies investigating this in order to get FDA approval using this technology identifies cancer left behind, which translates into lower re-excision rates.
So let me ask you
Not
another question.
surprising.
Yeah, which is
Yeah.
wonderful. This is so exciting. So let's just say it's the whole cavity is lighting. You take the specimen out, we see some lighting from the Luma system, and you take the fluorescent area that's lit up, you take that out. Will you see that? What happens after that? You've gotten the, is it dark? I guess is the question.
Well, again, every case is a little bit different, but yes, theoretically, you'd be excising the tissue that's fluorescing, and then once you've removed it, it's no longer fluorescing. That would be the goal. Yes.
That's way cool.
Yeah.
So then how do patients understand this and get access for this? This is really, I've taken this to the extreme because I want to empower anyone diagnosed with breast cancer to truly understand that there are so many innovations going on, as you and I talk about. But if I'm listening to this and I'm newly diagnosed, about to head into a lumpectomy, wow, I want this. I want to know more. How do they get access to understanding this and get it?
Well, I think what you have to appreciate again is the fact that there are complementary technologies. I think a more important question for your audience to ask of their surgeon is what's the re-excision rate?
That's good. Empower them to know. Yeah,
Yes. And if they don't know, they should know.
they should know.
Yes, every surgeon should know what their re-excision rate is. And if their surgeon has a 25% re-excision rate and the average is 15 to 20%, well, that may be an indication of whether they may want to get a second opinion. So, this is useful information. And if the surgeon has a low re-excision rate, well, I think you're relying on them using the appropriate technology amongst all those different complementary technologies we've discussed. So this requires time for adoption. So the reality is of all breast surgery done in the United States, I would estimate that less than 5% of breast surgeons currently have this technology. That's not that they don't want the technology. It's just simply that, well, the adoption isn't always that simple and straightforward. You're working in a healthcare system. You have to budget for this technology. So I wouldn't say, don't go to a surgeon that doesn't have this technology. No. What I would say is, please talk to your surgeon, understand what their re-excision rates are, and absolutely go to the Lumicell website. I don't know if they have a list of centers that currently are providing it, but I'd have to assume that they do. If that's something you want to look into, that would be the easiest way to look into it. But again, I do want to stress that the more important question to answer is, what's your surgeon's re-excision rate?
And this emotional decision between a lumpectomy and a mastectomy, or a double, like what I did, with these advances, getting a lumpectomy, as you and I always talk about, is it really gives a patient a chance to, I don't want to use the word whole because I might not have breasts, but I still feel whole. But a lumpectomy does give that patient an opportunity to conserve breast conserving surgery, which is, can be very important to some people who really want to keep their breast. So understanding these advances are really important, and knowing that there are many surgeons out there that have a low, recall back for surgery, if you will. And what leads me to ask the question about areas that have not such a big cancer center, hoping that these kind of advances get out to underprivileged areas that don't have the incredible resources that some of the bigger cancer centers have. It's important that, just even getting this message out there so people understand if they don't have access to some of the,
Yeah,
bigger.
I don't think it necessarily, innovative technology doesn't necessarily gravitate to academic centers, Cynthia. So I
Okay,
think
good to know.
it is always better to find a dedicated breast cancer surgeon rather
Yes.
than someone who is doing this maybe once a week or once every few weeks.
Yeah.
It's much better to go to someone who has a lot of experience doing this kind of surgery.
Yes.
But you don't need to be at an academic medical center in order
Okay, that's
to
good to know.
access that technology. Again, there's a number of questions you want to ask your breast surgeon.
Yeah.
But if you're facing a lumpectomy, one of the most important ones is what's your re-excision rate? Now, you have to be careful with that because what's a good solution to having low re-excision rates? Well, what about if you just have really, really large specimens? So if I have a woman who has a tumor that's this big and I do a lumpectomy that's this big, I'm going to have low re-excision rates, but I'm going to have poor cosmetic outcome. So you see how you have to balance that. It's not simple. It's
Yeah.
one piece of the puzzle. So it's a lot harder to answer that second question. What am I going to look like after surgery if I have a
Yes.
lumpectomy?
Yeah. Yeah.
But those are the conversations that you need to have with your surgeon before surgery so that you and your surgeon can manage expectations.
Yeah.
That's why I am a big fan of oncoplastic
Oncoplastic
surgery.
surgery.
Yes. So, what's oncoplastic surgery? That's applying plastic surgical principles to breast cancer operations to get the best cosmetic result without compromising cancer
Yeah.
treatment. You have to be careful not to dissect out one little small piece of an experience and extrapolate that to a simple yes, no, whether you're getting the care, the ideal care, or the care that
Okay.
you want, right? We've used this analogy before, but people make decisions with their brain and with their heart and with their gut.
Yes.
You have to really feel confident on all three sides that you're going to the right person.
Can I circle back for a second about Lumicell in the sense that how is this technology, this guided image technology, if you will, how does it differ from the traditional methods of identifying cancer during surgery? How is this uniquely different than what you're currently using?
That's very simple to answer. There is nothing like this. Yeah.
Oh, wow. Very cool.
You can't use anything to interrogate the lumpectomy cavity other than your finger and your eyes.
Wow. So
And
this
I
is
would not rely on either uh,
okay.
for identifying tumor because, as I said at the beginning of this, in many ways, you're operating blind.
And I don't think patients know that. And when we talk about DCIS, because I'm doing a whole new project on that, I mentioned earlier, that's a really difficult one, because you can't really, it's not invasive and there's a whole lot that goes on with that. Without Lumisystem to help with the surgery at the end in the cavity, how do surgeons determine if they got it all? How do you know if the cancer's all been removed? I mean, what are you using as a base, as a check mark
Well,
of
the simple
sorts?
answer is you don't know.
You don't know.
You don't know. You don't have any feedback. What we can do is, again, we can interrogate the specimen. So we take the lumpectomy and we take a picture of it. As I said, I can take a 3D picture of it. Well, if my mammogram shows that there is calcifications extending along 3/4 of an inch by 3/4 of an inch area of the breast, and let's say that it looks like a Christmas tree. And now I take a picture of that specimen. Well, I can see those calcifications, and now I can correlate what I'm seeing in the specimen with what I'm seeing on the mammogram. So that gives me some feedback that I'm removing the area that I wanted to remove. Now, what if that Christmas tree is going right up to the edge of the specimen? Well, it's a 3D image. I can go back and I can remove more breast tissue in that area.
Wow.
But you see, that's an indirect assessment.
Okay.
Using the Lumicite and the Lumicell Detect system, that's a more direct evaluation of that cavity.
But nothing like this. It's nothing like
Right,
this.
right.
Okay.
It's not perfect.
What excites you, Dr. Rosen, about this Lumicell system?
Again, it's just one more technology that gives us real-time feedback to take better care of our patients.
Right in the middle of surgery, which is really cool because nobody
Real
wants
time.
real time. Well,
No one wants to go back.
this has been incredible, Dr. Rosen. Is there any closing thoughts that you'd like to say to anyone who's about to get a lumpectomy, who's really trying to do their, empower themselves as we try to teach everyone to do the utmost research? What would you like to say?
I think you just have to, first and foremost, feel very comfortable with the people that you're working with. It is a team. It's
Yeah.
not just the surgeon. It's a large team of physicians and non-physicians that are working to guide you through this journey from the beginning when you're told that the mammogram's abnormal until you're looking for survivorship programs. So you really have to feel comfortable. Don't feel like there's a time bomb ticking. Don't rush your decision.
Okay.
The cancer is not growing like wildfire in front of your eyes. You have the time to make the best decisions for yourself and try to think of how you're going to feel a year later or 5 years later. Do you feel comfortable getting imaging going forward? Are you comfortable going through the roller coaster ride that we sometimes put people through with imaging? Would you be more comfortable with a mastectomy? Would you be more comfortable with a double mastectomy rather than a single mastectomy? There's no right or wrong answer. There's only a right or wrong answer for you as a person facing this. And my job and my colleagues' jobs are to help walk you through it so that we're collectively making the best decision for you, shared decision making.
It's really nice. I really appreciate that. And as always, Dr. Rosen, you break this down in a way that we can truly understand. And that's what we're trying to do here at Learn, Look, Locate. So thank you so much. I totally appreciate this. And anyone facing a lumpectomy, whole resource coming soon with Dr. Rosen to really get us more familiar with this option, because a lot of people don't really understand all the things that have to happen. And I really appreciate you explaining the different technologies that help you, the surgeons, feel as confident as you can that you're getting the cancer out. And that's why having Lumicell be part of this tapestry of innovations is really incredible. So thank you, Dr. Rosen.
Thank you.